talking about Hfref Pharmacotherapy. For the next 20 to 30 minutes, we'll be talking about heart failure, its pathophysiology, the subtypes of heart failure, the stages of heart failure, and Hfref Pharmacotherapy. So we all now know that heart failure is a clinical syndrome in which patients have typical symptoms and signs resulting from abnormality of cardiac structure and of function, which impairs the ability of the ventricle to fill or eject the blood. As far as the pathophysiology is concerned, there is a damage to the cardiac myocytes and or extracellular matrix, which leads to change in the size, shape and function of the heart and ultimately the cardiac wall stress. This leads to neurohormonal activation, which initially is beneficial, but later on it becomes pathological, leading to vasoconstriction, fibrosis, apoptosis, hypertrophy, cellular and molecular alterations, and myotoxicity. This ultimately leads to the heart failure signs and symptoms and the morbidity and mortality which the patients of heart failure face. As far as the heart failure classification is concerned, according to the ejection fraction of the left ventricle, heart failure has been subdivided into 3 subtypes. So the patients who have ejection fraction of less than 40% are classified as Hfref or heart failure patients with reduced ejection fraction. In these patients, the primary problem is the systolic dysfunction of the left ventricle. Then we have Hfmef of heart failure with mid-range ejection fraction, in which the ejection fraction of the LV is 40 to 50%, and in this the major problem is both systolic as well as diastolic function of the left ventricle. Finally, we have Hfpef or heart failure with preserved ejection fraction, in which the ejection fraction of the LV is more than 50%, and the primary problem here is the diastolic function of the left ventricle. Also, according to the degree of advancement of the disease, heart failure is also subdivided into 4 stages. So stage A are those patients who are at risk of heart failure but do not have any signs and symptoms of heart failure. Then we have stage B or pre-heart failure. In this, the patients do not have specific signs and symptoms, but yes, they are at very high risk because they have some sort of structural heart disease or some sort of evidence on imaging of increased filling pressures of the left ventricle. Then we have the stage C, in which we have the patients who had symptoms and signs of heart failure or who are currently having symptoms and signs of heart failure. Finally, we have stage D, in which we include patients who have advanced heart failure. So basically these patients are those who are already on guideline directed medical therapy, and despite the fact that they are on guideline directed medical therapy, they have symptoms. So to begin the treatment, we will be discussing in detail the treatment of stage C, that is patients who had any symptoms or who are currently in symptoms of heart failure. Before starting on the pharmacotherapy, I'll just touch upon the non-pharmacological measures which can change the morbidity and mortality in this group of patients. So we now understand that all the heart failure is a chronic condition. So these patients require multidisciplinary team approach to facilitate their treatment, optimal treatment, to facilitate the potential barriers they have to self-care and reduce the risk of hospitalization. We now understand the importance of vaccination, especially against respiratory illnesses. We understand that these patients require screening for depression, social isolation, frailty and low health, because that is ultimately linked to the long-term outcome of these patients. Finally, all these patients should avoid excess salt intake and should have proper exercise training or regular physical activity or cardiac rehab in order to improve their symptoms and signs. So before going on the guideline directed medical therapy or the medical therapy which is targeted to the pathophysiology of heart failure, especially Hfref, just a word about the diuretics and decongestion strategies in these patients. So most of the patients who have fluid congestion, they require loop diuretics, and loop diuretics are in fact recommended as a class 1 agent in these patients who have congestion, because not only they improve symptoms, they also improve their 30-day mortality, and this has been well documented in various trials like the optimized HF trial. We also understand that those patients who are not completely responding to say loop diuretics, or who are having suboptimal results, you can add on other class of diuretics, especially the thiazide like metolazone, which has an additive effect over loop diuretics. Just to touch the word diabetic resistance, we must understand that these patients are on long-term diabetic therapy, so they can face a condition known as diabetic resistance, in which the response which was previously attained with the loop dieters is subsequently not obtained. And in these patients, we can try different strategies like, increase the dose of loop diuretics, or you can go with the IV diuretics, or you can add other class of diuretics like metolazone. Now, whatever treatment you are using for patients with heart failure, you need to understand what is the initial dose you have to start with, and what is the target dose which has been used in most of the trials, or most of the studies, and the patient have benefited the most. So if you're keeping the patients of suboptimal treatment, they won't get the maximum benefit out of your therapy. So despite the fact that you have put the patients on guideline directed medical therapy, the benefits might be suboptimal because they are not getting the optimal dosage. So as far as diuretics are concerned, you can start furosemide at a dose of 20 to 40 milligram, go up to as high as 600 milligrams. For torsemide, you can start at a dose of 10 to 20 milligrams and go as high as 200 milligrams. For metolazone, you can start with 2.5 milligram once and go up to as high as 20 milligram once a day. Now, specific pharmacotherapy which is targeted to pathophysiology of Hfref includes the basic 4 pillars in the form of RAS inhibition, beta blockers, SGLT2 inhibitors, and mineralocorticoid receptor antagonists. In addition to that, according to the individual need of the patient, you can add on IVRN, digoxin, ivabradine, isolazine, and vericiguat. So let us start with the specific therapy, or you could call that guideline directed medical therapy, or therapy which targets the pathophysiology in patients with Hfref. So we start with RAS inhibition with ACE inhibitor, ARB, or ARNI. Now, most of the societies, the international guidelines, they clearly recommend that it is a class 1 indication to start a patient of Hfref having class 2 to 4 NYHA symptoms on ARNI. So unless contraindicated otherwise, you need to put all the Hfref patients with NYHA class 2 to 3 on ARNI. If the patient cannot tolerate ARNI, or is not able to take ARNI, then you can put the patients on any ACE inhibitor, and if the patient is not tolerating ACE inhibitor and ARNI, you can put the patients on ARB. We have sufficient data to support the fact that ARNI is the first choice for RAS inhibition in patients with Hfref, like the various trials like Paradigm HF trial, the Pioneer HF trial, or the Transition trial. Yes, it's true, if the patient cannot afford or cannot tolerate RAS inhibition with ARNI, you can put those patients on ACE inhibitor and ARB, which again have equal data in terms of their efficacy. Again, I repeat, just putting the patients on guideline directed therapy won't matter unless until you put them on a dose which has been used in most of the trials or studies, or the dose which has shown proper improvement in these patients. So just selecting the agent won't help. You need to have the idea about how much dose is required. Say for example, ramipril, you can start with 2.5 milligrams a day, and you must try to achieve the dose of 10 milligram once daily if the patient tolerates. So that would give the maximum benefit to the patient by RAS inhibition through ramipril. Similarly, for valsartan, you can start at 40 milligram once a day, but you must try to increase the dose up to 160 milligram twice daily. Similarly, for ARNI, you can start with 50 milligram twice a day, but you should try to increase the dose to 200 milligrams twice daily. Beta blockers, again in Hfref patients, using one of the 3 specific beta blockers is a class 1 recommendation by most of the international societies and guidelines. And you need to understand not all beta blockers are the same, and only 3 beta blockers have specifically shown improvement in terms of morbidity and mortality in patients with Hfref, and these 3 beta blockers include bisoprolol, metoprolol, and carvedilol. Also, you need to note that it has been clearly mentioned that even if the EF improves, continuation of beta blocker has shown to reduce the risk of progression of LV dysfunction or major cardiovascular events in this group of patients. And I think beta blocker should be almost continued lifelong in group of patients who have Hfref and who have subsequently shown improvement. So these patients usually require long-term or almost lifelong beta blockers. Again, you must be aware about the dose that would maximally benefit the patients. So for bisoprolol, you can start with 1.25 milligram once daily, but you need to titrate it up to 10 milligram once daily if the patient tolerates. So if your patient is tolerating, take care that you titrate the dose up to the therapeutic dose which has been used in most of the studies, because this will give the patient the maximum benefit. So you need to increase the dose of bisoprolol to 10 milligram once daily if the patient tolerates. Similarly, for carvedilol, you can start with say 3.125 milligrams twice daily, but try to increase it to 25 to 50 milligram twice daily. Similarly, for metoprolol, we can start with 12.5 milligram once daily, but try to achieve 200 milligram once a day if the patient tolerates. Mineralocorticoid receptor antagonist, again Hfref patients with class 2 to 4 symptoms. Mineralocorticoid receptor antagonists have been recommended as a class 1 drugs because they reduce both morbidity and mortality. But there is a caveat here. You need to take care that the whomsoever patient you are putting on mineralocorticoid receptor antagonist, the eGFR is more than 30 and the potassium levels are less than 5, and you require monthly, bi-month, or twice, once in 2 months monitoring of the eGFR and potassium levels so as to prevent incidence of hyperkalemia or arrhythmias. Several clinical trials like the RAILS, the FSS and EMPHASIS HF trial, they have clearly shown that mineralocorticoid receptor antagonists, they act across wide spectrums of Hfref. So whatever may be the cause of heart failure with reduced ejection fraction, mineralocorticoid receptor antagonists have clearly shown benefit in different subgroup of patients with Hfref, and even in not only different subgroup of patients, they have also shown benefit in different severities. So it might be a very severe Hfref or mild Hfref. Still, MRAs have clearly shown benefit in terms of reducing the morbidity and mortality in these group of patients. Again, you need to understand the dose. You can start with 25 milligram of spironolactone or eplerenone, but try and achieve 50 milligram once a day if the patient tolerate in all the patients you are putting on MRAs in Hfref. SGLT2 inhibitors, these are all recent molecules, but yes, it has quickly become a class 1 agent to be used in Hfref patients who are having symptoms of class 2, 3, and irrespective of the fact that they have diabetes or not. Now we have large trials like the DAPA-HF and the EMPEROR-reduced trial, which have clearly shown that SGLT2 inhibitors as compared to placebo have reduced the morbidity and mortality by almost as high as 25% as compared to placebo. And morbidity and mortality is specific in terms of reducing the cardiovascular death or heart failure hospitalization, and 25% is really a large number. The dose for SGLT2 inhibitors is quite it's a single OD dose, and you need not up titrate. Also, you can directly start with 10 milligrams of either empagliflozin or dapagliflozin and continue with the same. Word about the hydrolazine and isosorbide dinitrate, or isolazine, commonly known as in the market. Well, not a very class 1 agent, targeting any pathophysiology, but yes, patients who are of African American descent and who have been on all the 4 pillars of heart failure but still having symptoms, those patients being put on hydrolazine and isosorbide dinitrate, they have clearly shown benefit by the addition of it. And we have large trials like the Vhef trial or the Ahf trial, which have shown benefit, especially in African American population. So apart from the 4, or you can say 5 drugs which we discussed, we have other drugs also, which can benefit patient with Hfref, but they, benefit a specific group of patients, and you need to identify the patients which would benefit by these drug treatments. First of all, you need to take care that you have put all your Hfref patients on the guideline directed medical therapy, that is the basic 4 pillars. Then just evaluate the patients that whether they have any residual symptom, or they have any condition which can be further corrected by other drugs like say ivabradine. So ivabradine is indicated in patients who have been on GDMT, proper beta blockers, still have a heart rate of more than 70. Ivabradine certainly reduces the morbidity and mortality. Similarly, if the patient has recent hospitalization, is on IV diuretics, and has raised BNP, was already on guideline directed medical therapy, vericiguat has a role to play. Digoxin especially has a role to play when the patient has biventricular dysfunction, and especially with atrial fibrillation. Similarly, patients who are on guideline directed medical therapy and still experience symptoms, you can also try polyunsaturated acids, because they have shown some benefit. PUFA have shown some benefit in certain group of patients. Finally, patients who are on RAS inhibition and MRAs and have slightly raised potassium, say about 5.2, 5.3 or 5.5, potassium binders have clearly shown benefit in terms of reducing the events of hyperkalemia or arrhythmias in this group of patients. Now, how do we start all these drugs? How do we sequence it, and how do we uptitrate it? Well, in patients with Hfref, titration of guideline directed medical therapy, as I just discussed, is very, very important. Just putting the patient on a drug won't help unless and until you have achieved a proper dose which has shown benefit in majority of the studies or the trials. Similarly, if someone asks about the sequencing, which drug to start first, well, that depends upon individual patient according to its symptoms, signs, functional status, tolerance, renal function, electrolytes, comorbidities, and the specific cause of heart failure. So it cannot be one cloth fitting all. So you cannot have a common protocol for all the patients. You need to individualize the sequencing in different patients according to the specific needs. And but the common platform would be that you try and put all the patients as soon as possible on all the 4 guideline directed medical therapy and the other therapies if the residual symptom remains. So just to summarize what we have discussed over the past 15-20 minutes, how do we approach a patient with Hfref? So once you have a patient with Hfref, see to it that you have confirmed it with investigations which include blood investigations, ECG, echo, or an MRI. And if you have confirmed the patient that he is a patient of Hfref, then the patient needs to be kept on the guideline directed medical therapy, which includes the 4 pillars in the form of ARNI, ACE/ARB, beta blockers, SGLT2 inhibitors, and MRAs. So these are the 4 pillars of heart failure, what we call, and all the patients should be put on these 4 pillars plus minus diuretics, that is loop diuretics, depending upon the congestion state of the patient. The next step would be, as we discussed, just putting on the drug won't help. So you have to try and titrate to the maximum tolerated dose of the drugs you have put the patient upon. So you have to try and up titrate most of the drugs, because the maximum dose which have been shown in various trials and studies, they reduce the morbidity and mortality, and not just putting the patient on a particular drug class achieves the reduction in morbidity and mortality. Next step would be to evaluate whether the patient requires something extra in the form of, say, you can say implantable devices. If the patient says having broad QRS, the patient is having less than EF of 35%, and has the expectancy of more than 1 year. So if the patient is having a EF of ejection fraction of less than 35% and a life expectancy of more than 1 year, we can offer the patient implantable cardiac defibrillators or CRTD if the patient has a broad QRS and dysynchrony on echo. Similarly, as we discussed, if the patient is of African American origin, we can offer him isolazine. At this point, if you have given these patients all these drug therapy and implantable devices, you can again reassess the patient. If the patient has any special requirement or residual symptoms, say for example, if the patient is already on guideline directed medical therapy, beta blockers, still has heart rate of more than 70, you can offer the patient ivabradine. Similarly, if the patient has biventricular dysfunction along with atrial fibrillation, you can offer the patient digoxin. If the patient was already on guideline directed medical therapy and despite the fact has recent admission, heart failure admission with raised BNP, is on IV diuretics, you can offer the patient vericiguat. And you can also offer the patients PUFA if the patient is already on guideline directed medical therapy and still has some symptoms of class 2 or class 3. The step 4 and 5, as we discussed, were assessing the residual symptoms and putting the patients on implantable cardiac devices or other therapies apart from the basic pillars of heart failure. Then we need to assess whether once you have put the patients on all guided directed medical therapy and you have added on therapy for residual symptoms, if still the patients remain symptomatic, then we have this step 5 and step 6, that is referring the patients to special centers, because if still the patient remains symptomatic, he requires special treatment in the form of cardiac circulatory support devices, what we call artificial heart, or the patient might require complete permanent cure in the form of cardiac transplantation. We at our center serve as a center of excellence for ventricular assist devices, that is circulatory supports, as well as for heart transplant. So we need to refer the patient to a higher center who deals with such things. So with this, I think we end our talk. Thank you all for your patient hearing, and I would be really glad to answer any queries if any of the participants is having. Thank you so much.